All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. And as usual, we have one more rock star with us, Dr. Marc A. Levitt. He is with us the second time over. And you can actually see with the credentials of the guests that we have that how amazing the ambience of our neighborhood is, or of Dr. Bean is. And I am so grateful that Mark has given us time once before, now, and will continue to do this series. So, Mark, very quickly, let me introduce you with your bio here. So these links are in the description as well. This is Children's National Hospital. Meet Marc Levitt, MD. So if you see here, Marc Levitt, MD, colorectal and pelvic reconstructive surgeon. This program, so he's leading a program in the Children's Hospital, colorectal surgery program. This program will be the first in the mid-Atlantic region to fully integrate surgery, urology, gynecology, and gastroenterology into one cohesive program for children. Dr. Levitt is an internationally recognized expert in the surgical care and treatment of pediatric colorectal disorders. He has performed over 10,000 surgeries to address a wide spectrum of problems involving the colon and rectum, more than any other full time practicing pediatric surgeon in the world. So, this is amazing. So, thank you very much for being with us, Dr. Levitt.
And it's hard to believe since I only just graduated from medical school.
We all feel that way, isn't it? Not that we are any
I
old,
wish.
we are
I
pretty
wish. I
young.
wish.
But 10,000 surgeries, many of my class fellows are surgeons as well. And it is 10,000 surgeries. I mean, more power to you when you keep helping people. That's a lots of experience, lots of help. And for the cool beans here, this is Children's National Hospital's link. Disclosure, I'm sure that Dr. Mark doesn't have disclosures. He can speak about himself. I have no disclosures. This is drbeen.com. Most of these videos end up on drbeen.com as well. And in the link in the description on YouTube, there is a special discount link, which is almost like a gift price. You would never find that kind of a price again. So maybe take advantage of that. With this, uh, first of all, I'm going to go back to Mark. Mark, please tell me, how are your days nowadays? How is your work? What's happening?
Well, it's been routinely pretty busy. Even though there's been a pandemic, we really have remained very busy in colorectal surgery because kids still need our help, and their surgeries are all considered what would be described as semi-urgent. So we have been very steady from the very beginning of the pandemic, and lots of kids need our help with reconstruction based on the fact that they were born without the right colorectal anatomy and therefore can't evacuate stool. And then we have many patients a little bit later in life that have had surgery, many times have been done elsewhere, and then need some help with bowel training strategies. And then there's some surgeries that we can do to improve patients who have fecal incontinence. So I operate 3 full days a week. I have a clinic 1 day a week, and I have meetings and academic sessions the other day a week, the other day of the week. So, and I like being busy. So happy to
Well,
help.
thank you very much. Thank you for your work. Thank you for your service. And let's start our discussion. So, cool beans. The topic for today, Hirschsprung disease, second part. We did the discussion last time about the disease and the surgical approach to it. Now is the second part, and that is the long-term considerations about the Hirschsprung disease and the post-management aspects. So, I'm going to go to that slide. So here we are.
Yeah. So we talked through the first session, and I would encourage those of you to make sure to get that background and review that session. But we talked through the first session of how to diagnose Hirschsprung's, and then how to treat Hirschsprung's surgically, and some of the nuances of the radiology and the diagnosis, etc. And most of the time, things go very well, and the surgery is successful. and the child stools normally and doesn't worry too much about that physiology process. But there are a number of patients who don't succeed after surgery, and centers like ours here take care of such complicated patients and try to get them on the right path, stooling well, emptying their colon, having bowel control, eating normally, growing, all of those wonderful things that we want our kids to be doing. So this second half is the evaluation of the child post Hirschsprung surgery who is not doing well. And many times they have a problem that can be fixed. So that's what this session is going to cover. So let's see what we have as the
Got
next.
it. Thank you very much. So should I go to the next one?
Yes, please. So the two problems, the two things that can go wrong are either the child has had surgery and does not empty well. I would call that obstruction. And some of the manifestations of obstruction, of not emptying their colon, include a condition called enterocolitis, which is an infection, diarrheal disease related to Hirschsprung's disease, failure to thrive, so a child is not growing, and chronic distension, where they're always distended in the abdomen, and this has manifestations of pain, not wanting to eat, things like that. So that's one problem. The other problem is patients who soil, patients who cannot control the bowels and have accidents. And I break those into two parts. Those, and there's a misspelling here in my slide, but those with pseudo-incontinence, which means that they have the potential to be continent, but for whatever reason, which we will discover, they aren't clean and are having accidents. Or those that have true incontinence, meaning they do not have the anatomic elements to successfully have controlled bowel movements. And we also have treatments for them if that is the case. So
Got it.
let's delve into these two halves. So first off, and this is really vitally important for the surgeon and for the gastroenterologist taking care of a patient with Hirschsprung's disease, is to know the type of pull through that they had. And we talked a little bit about this the first time through, but there are basically three main types that are done today. A Swenson pull through, where the entire abnormal segment of colon is removed, and the healthy part, the ganglionated part, the one with the nerves, is brought down and connected right where you're pointing to the anal canal. The Suave procedure is similar, but the dissection around the rectum is within the wall of the bowel. We call that submucosal. And then the outer shell, the original outer wall, is left behind, and the pull through is done there and connected to the anal canal. And that operation was devised because surgeons were doing the full thickness dissection of the Swenson too wide. They were dissecting too wide to the rectum, and there were some injuries to the nerves that were occurring, and the Suave was developed. However, the unfortunate consequence of that brilliant idea was to leave behind the outer wall, and the outer wall can cause trouble. We call that outer wall the Suave cuff. And then the third type of operation is called a Duhamel, which was also developed to respond to the way the Swenson was being done incorrectly, where the original rectum, a little piece of it, is left behind, and the good bowel is brought down, and the two parts are mated together to make a single lumen, half good bowel, half not so good bowel, with the hope that the good bowel will dominate and allow the colon to empty. I personally do a Swenson, but I do a Swenson in the correct plane and have not had the problems that were originally described in the 40s and 50s, 1940s and 50s, related to the Swenson. So I believe the Swenson is the ideal operation, but you need to know which of those operations were done so you can figure out how to solve the patient's problem.
Got it.
Okay, so this is a really a nice slide also, which basically shows the different operations, which essentially is what I just said. On the Swenson side, the healthy bowel is, you see in pink, and the original anal canal is preserved. You see that in yellow, and the blue represents the anoderm. So the good bowel has now been mated to the original anal canal. Next slide. Okay, so in the Suave, very similar idea, but the yellow on the sides is that cuff I was talking about. So that's the original outer wall, and that can cause trouble sometimes. It's called the Suave cuff. And in the third version, you now see the healthy bowel is in the pink, and the original part of the rectum in yellow is left behind, and where the dotted line is, that tissue in between the two tubes is removed, so functionally is a single lumen, single pull-through. Okay, so that's not that interesting except for those of us who nearly need to understand the anatomy, and I would include pediatric surgeons taking care of Hirschsprungs and gastroenterologists taking care of Hirschsprungs in that group. Okay. So the other thing we need to know is there a problem with the colon? And I think to anyone's eye, you can see that these two colons are very different. The one on the left, the downstream part where the colon is going to empty, so that part is narrow. That is a colon that is moving rapidly, quickly. I would call that hypermotility. It's moving too fast. Maybe think about diarrhea. It's moving 4 or 5 times a day. Well, that, of course, can cause soiling. The image on the right is a colon that's moving too slow. It's a dilated colon. That's a colon, maybe it's only emptying every second or third day. And of course, that can cause trouble on the grounds of constipation. So we need to know the status of the colon. Is it a fast colon or is it a slow colon? A fast colon needs to be slowed down. A slow colon needs to be sped up. Okay, next one. And I don't need to go into too much detail, but this is an algorithm for those of us who work on this problem of how to evaluate such a patient and try to come up with the explanation as to why they are not emptying. And essentially that begins with the top box, and we have to do an examination of the pull-through, a rectal exam and a contrast study. We need to understand the anatomy of the pull-through and why it's not working. Essentially looking under the hood of the car that you're trying to fix to find out why it won't start. So there are a number of things that can go wrong with the pull-through, and I will explain some of these examples soon. Next slide. All right, so one example is a stricture, and this is essentially scar tissue. You can see on the right, there's a very small circle. That should be much wider, and that white tissue is scarring of the pull-through, and it relates to a narrowing that results from loss of blood supply or excessive tension related to that pull-through. And on the picture on the left is the dilation that you can see that is upstream above the narrowed area. So you can think about that like a traffic jam. If there is a traffic jam, all the cars back up, and that's essentially what's happening in that segment of the colon. All right, let's go to
So
the next one.
is there a solution for this, or
Yes, there is a surgical solution to remove the narrowed area, which you see there, and pull through a slightly higher portion of the colon, because you know that where the dilated part is good. It's trying to empty, but we need to remove the obstruction, which is at the bottom, the narrow part. You can actually see it birds beaks a little bit at the bottom. The white at the bottom comes quite narrow. If we widen that circle, then the colon empties better.
So wouldn't this scar appear again?
Well, the reason why the scar appeared is because of lack of good blood supply or tension at the original pull through. So if you accomplish a pull through without tension and with maintained good blood supply, it should heal like a nice sized circle.
Got it.
All right. Well, this one I think you can see as well. The pull through, which comes from the abdomen in towards the anal canal, the surgeon can inadvertently twist. And you can see the corkscrew on both of these images. You can see that. Yes, exactly. I almost feel sometimes that you are a surgeon. You
No, I just
immediately,
take clue from you and kind of go there.
I don't think so. I think you have an anatomically based medical analysis. That's my impression. So
Thank
you can see there's like a corkscrew there, and imagine that the child is trying to pass stool through the corkscrew. It's not going to be very effective. So the solution here is to disconnect the pull through, twist it, or untwist it, I should say, and then redo the pull through in the same location, and then you'll have a successful pull through.
Got it. One question: how do we find out that there is a problem? Is it that patient is not able to evacuate anymore, or they start developing pain, or we do a follow up anyways, and in that follow up it shows up?
No, all of the above. They have symptoms. The symptoms, as I mentioned, are either they don't empty successfully, they have pain when they attempt to empty their bowels, they develop what's called enterocolitis. Enterocolitis is a inflammatory reaction leading from poor emptying, and they can get quite ill from this. It's diarrheal, and they can get quite sick. And it comes from stasis, from obstruction. A patient without Hirschsprung's disease who doesn't poop well gets more and more constipated. A patient with Hirschsprung's disease who doesn't poop well gets very ill. Why? Because the lining of the bowel has a deficiency in the immune cells that prevent bacteria from entering the bloodstream. That just happens to be part of Hirschsprung's disease. So stasis in a Hirschsprung's patient is very problematic. The patient can get quite ill, whereas stasis, no flow in a non-Hirschsprung's patient, just leads to more constipation. They don't get terribly ill.
Got it. Thank you.
So here's some really cool surgical photos. This is the contrast study on the left, and you sort of see that the pull through has been narrowed at the very bottom, almost like no, a little higher than that, where the narrow port right there. It seems like something is squeezing it from both sides. And basically, imagine there was a hair tie or a rubber band around that pull through. That is the cuff that I mentioned earlier, the retained cuff. And surgically, on the right picture, you can actually see what that cuff looks like. There's like this rubber band that you can find. And if you remove the rubber band, there is no longer a strangulation around the pull through, and the obstruction is relieved. Very important. You can feel this on rectal examination. You can see it on the contrast study, and it has a pretty easy surgical fix once you've made this diagnosis.
Got it. A very quick question from Kelly. Kelly says that how often is imaging done post pull through surgery to confirm a problem, especially in children who can't yet clearly communicate discomfort?
We would do imaging that you're mentioning when the patient does not pass stool correctly, even if there's not an obvious explanation of where the discomfort's coming from. But on just a regular old x-ray, very simple x-ray, you can see distension. You can see that the air is not making its way through, and then further imaging is warranted.
Got it. Thank you very much.
So this is a pretty severe manifestation of a cuff problem. This patient had not only a cuff, but also developed an infection, an abscess, and you see that funny stranding of contrast. That obviously is abnormal, and that's related to an infection in the area of the cuff. As I said, if you do a Swenson operation, there's no cuff, you don't have this problem.
Got it.
All right, so here's another problem that can ensue, and this is something we would figure out both by how it looks and also on a biopsy. If you look at the image on the left at first, you'll notice that the bottom part is quite narrow. And in a patient who's not emptying, why would it be narrow? Well, maybe the surgeon originally did not pull through enough bowel and did not reach the good segment of bowel, the ganglionated segment. And the operation is done, and you can see it on the right. And I think you can even see that the healthy bowel from the right colon to the transverse colon, so that's the bottom. Start on the other side. There you go. You can see that it looks good until right there, but go slowly up, up, up. And then right there it gets to be dilated. To the left of where your pointer is, the bowel is healthy. It's contracting. Where your pointer is, it's now dilated all the way down. Looks very smooth walled. It's not contracting. It doesn't have that nice muscular contraction that you can see on right there. You see that? Those little narrowed areas are peristaltic waves. That's the bowel contracting in a normal way. But the left colon, the dilated portion, is not doing that. And that entire segment is abnormal because it's not contracting normally. Because in order to contract normally, you need normal ganglion cells. Excuse me for 1 second. There you go. Okay. Now, another problem that can ensue is a patient who has had the Duhamel operation. And remember, I explained to you that there are two sides to the Duhamel that need to be united into a single lumen, the ganglionated side and the original rectum. So half good, half bad, with the hope that half of good is enough to empty the colon. Well, if those two sides are not adequately separated, and here you can see that the wall between the two sides has remained intact. And you have that this metal instrument is passing into one of the lumens. The other lumen is the little cave, the little dark area above. And now we've come in with this special instrument on the picture on the right, and we are going to get rid of that common wall. If you had two rooms in your house,
Is this the one?
that's the wall, exactly. If you had two rooms in your house and you wanted to make a big room, you'd have to knock down the wall that separates the two of them. So now you have a single room, much bigger room for your family room. That's exactly what we're doing. We're uniting the two sides, which should have been done at the original surgery, but wasn't done to completion. And that leads to a problem that can lead to obstruction.
Got it. And just for my curiosity, these two the wall between the two lumens, is any one of them blind, or they both are connecting up?
Well, one is blind because that's the original rectum.
Correct.
And the other goes all the way up into the rest of the colon.
Got it.
And actually, interestingly, the blind one collects with stool and then presses on the other one. So it presses through that common wall and obstructs the pull through. If you remove the common wall, it can't do that. You have removed the spur. That's called the Duhamel Spur.
Got it. Got it.
Okay. Now, this is an algorithm to manage the patient who is soiling. This is the other half of that coin. not the obstructed patient who's having significant obstructive symptoms, but rather a patient who simply is having accidents, not simply because it's a complex problem, but who is having accidents without obstruction. They are soiling. And likewise, we need to do an exam under anesthesia and figure out the anatomy and come to a conclusion as to why they are soiling. So let's go to the next slide and I'll
Got
explain
it.
some of that.
Just one quick note. Bella Bean is saying that Dr. Bean, what causes it? Bella, we had that detailed discussion last time about the Hirschsprung, and this is a problem where there are some ganglions or the nervous system for the gut is not developed correctly, and then there is a lot of further processes to understand for the pathology. So I would please request you to look at the last video. I would link that after this talk. I would link that to this talk as well. Back to you, Dr.
So one of
Levitt.
the anatomic problems that we try to figure out for a patient who's had Hirschsprung surgery and is soiling is how are their sphincters? And these are two pictures of the anal area. And the picture on the left is quite normal. It's closed. Both these patients are awake. The patient on the right, the sphincter is open. The term I would use is patulous. It's lax, it's widened. And this has resulted from this original surgery that has overstretched the sphincters so that they don't contract back. Now, here you have a patient who wants to squeeze those sphincters and close the anal canal so stool does not exit, and they are unable to do that because the sphincters have been weakened at the time of the original surgery. So that's the first thing. Are the sphincters okay? Now, one very cool thing is that we have developed here an operation to make those sphincters tight again, a sphincter reconstruction, if this were to happen. All right, let's go to the
Got it.
next slide. All right, now in addition to the sphincters, you need to know whether the anal canal, also known as the dentate line, that is the area of the body that is responsible for sensing what is happening just before the stool exits the anus. And it is a very important part of the body. It's as sensitive as your fingertips. And this part of the body can detect solid, liquid, or gas. The picture on the left is a normal and intact and healthy anal canal. The picture in the middle does not look the same as the picture on the left. The picture in the middle, the anal canal has been inadvertently removed by the surgeon. They started their operation too downstream, too close to the edge of the skin. So the pull through is directly to the skin, and they have lost the capacity to detect solid, liquid, and gas by losing that very precious 1 centimeter of anatomy. And in the picture on the right, you have a little bit of the anatomy preserved, but some of the circle is lost. The anal canal is lost. So this, of course, can affect the child's ability to have control if you don't have the sensation required for bowel control.
So what does this child do then? They don't have any anal canal anymore, so they have lost the ability to sense. Would they never now understand if it is gas or stools or?
That's correct. But their sphincters might be good enough to hold in the stool, provided they have a cue that stool is there. And the only way they can achieve that is if the stool has some bulk. So they may be able to feel distension of the stool and quickly close their anal canal with the muscles that they have and reach the bathroom on time. And they don't have the benefit of the anal canal to tell them whether it is a solid, a liquid, or a gas. If such a patient also has deficient sphincters, they will not have bowel control. And then that patient will need a mechanical way to empty the colon. And there are ways we take care of that too, either a rectal enema Or
Mm,
amazingly, you can give an enema through the appendix. That's called a
mm,
Malone appendicostomy. And
mm.
spoiler alert, we will be talking about that at a future discussion, um, because that is a surgical way to overcome the loss of continence in a patient like this.
Got it. So, why does this happen? I mean, this seems to be a very important thing to know for a surgeon, to say that, hey, this little 1 centimeter of the inner canal should be left out there. Is this just a an accidental mistake, or that is lack of experience, knowledge, or
Yes,
something else?
it's a difficult question to answer, but yes, it's a unintended consequence of the surgery if the surgery is started too low. I have a
Got it.
special process, a special technique whereby I intentionally preserve the anal canal before I start the operation, and I teach that, and so this problem should be avoidable.
Got it. Thank you very much.
All right, so these are some pretty horrible pictures of lost dentate line and lost sphincters and the terrible rash that can ensue. And I apologize for these somewhat graphic images, but we are talking about surgical problems here. That is a very terrible chronic rash on the right, and that patient, in order to do okay, probably at that point needs a bowel stoma, an ileostomy or a colostomy to protect that segment of their body from getting any stool at all, and then let that heal. And that's a patient who unfortunately might need a permanent bag because they have both lost their anal canal or their sphincters. I will say nowadays, since I've developed this new technique to reconstruct the sphincters, we have been able to help some of these patients who previously had no real good option, because we can tighten
Mm,
those sphincters and make them hold the stool a little bit better. Because
mm.
usually the sphincters are there, they have just been overstretched. So they need to be brought back in to the circle that they once were.
Got it. Thank you very much. So, of course, this is a horrible outcome for a poor child, and these rashes are because of continuously leaking fecal matter and being present there.
Yes. The good news is we usually can help this patient with changing the consistency of the stool, getting them to stool on a fairly regular basis, giving them some dry periods so that the skin has a chance to heal, and sometimes doing that sphincter reconstruction I was talking to you about.
Got it.
All right, a brief word on total colonic Hirschsprungs. This is not necessarily a problem. It doesn't necessarily belong in the problem section of this talk. It is one of the ways of handling Hirschsprungs of a unique type. I mentioned it last time where the entire colon is involved, but for patients with no good colonic ganglionosis, those patients only have good small bowel. And then they need an operation whereby the small bowel is brought down to the anus. Very similar to if you've heard of ulcerative colitis or if you've had another discussion on that topic. Those patients also may sometimes need their colon removed and the ileum, which is the small bowel, the end of the small bowel, brought down to the anus.
Got it.
All right. And before their pull through, this patient has a likelihood of having very loose stool, obviously, because the colon is very dependent. You are very dependent on a colon for forming solid stool. So, some of the things we do before we do the pull through, they always have an ileostomy when they're a baby. And then one day, their ileostomy can be pulled through. We give them various types of fiber. We also give them sometimes loperamide to slow down the stool. And then we wait until the stool is thick. And once the stool is thick in their stoma bag, then they can undergo their pull through. And that takes place somewhere between 6 and 18 months of life.
Got it. Sorry.
Okay, I think the next one shows a picture of total colonic Hirschsprungs, that the only segment of the bowel, maybe you can find what I'm talking about here, but on the top left is the colon. That's no good. And then the ileum is narrow for a while, narrow, keep going, narrow, keep going, narrow, 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 narrow. And then it gets to a point right about there, a little bit lower, where it starts to look more normal size and a little pinker. So that's
Mhm.
healthy ileum. The rest is all aganglionic. So in this case, the entire colon and about 15 centimeters, maybe about a foot of the ileum is also no good, but you can survive quite well even with this amount of colon and small bowel that needs to be removed. In the newborn, you would make an ileostomy where the bowel looks healthy and wider, right around where your pointer is. And then the baby would grow. And as soon as the ileum has the capacity to form solid stool, you can do your pull through.
Very interesting. So, don't they develop any absorption issues because ileum is busy in helping with the absorption, or they can
Well,
grow a.
they as long as they have enough small bowel, and this patient has enough small bowel, they can absorb completely normally. All of our nutrition is absorbed in our small bowel. The colon's really only job is to absorb water. And absorbing water allows one to have solid stool. So if you don't have a colon, it's much harder to create solid stool. You can do it, but someone with a colon will stool once a day or every other day. Someone without a colon is going to stool at least 2, perhaps up to 6 or 7 times per day. They can have control because their sphincters and their anal canal were preserved, but they are going to the bathroom more frequently because there's less water absorption.
Got it. Thank you.
And then here is some fairly sophisticated recommendations for the clinicians on the call when you have to manage a patient who is moving very, very quickly. And we don't have to go over too much of this detail, but basically it involves slowing down the stool, improving hypermotility, and treatments of the skin with various diaper rash creams, etc.
Got it.
All right, and that brings us to the conclusion of the discussion of the problematic post pull through Hirschsprung's patient. And at the end, we included a little bit about total colonic Hirschsprungs, in which you have to pull through the small bowel.
Thank you so much. This is
And I see,
reminds
by the
me
way,
of my.
I'm sorry to disturb you, but I see in the background of my camera is my wonderful program manager. So just so you know who they're looking at, Julie Schwakey is there in the background, who runs our wonderful center here in Washington D.C. And we are so connected in our work that we share an office. So just didn't want you to think some random person was hovering in the background. She could give the talk too. She knows so much about Hirschsprung's disease. The only thing I get to do is the surgery.
I never tire of hearing
Awesome.
it.
Thank you very much, and nice to meet you.
Nice to
Um,
meet you as well.
yeah. So this whole discussion reminds me of our school medical days where professors would come in and they would talk to us with us about various surgeries and processes. So thank you very much. Um, a few questions, if we can. One is, Kelly says, I'm curious if Dr. Levitt has encountered patients with inherited collagen disorders like Ehlers-Danlos, for example, and if those patients have more problems post-surgery.
That's a good question, Ehlers-Danlos, and there are a whole bunch of collagen disorders. We do take care of patients like that. They tend to have some constipation, so we see them for that. And certainly patients with Ehlers-Danlos can also have surgical conditions that we manage. They usually heal quite well. There are some limitations in their healing, that's for sure. But I think if you're just aware of it and proactive about management of the healing, it's usually of no concern. You just have to know that the diagnosis exists. It's a patient who you might be a little bit more careful about checking the anal connection, making sure it's not scarring down.
Got it. Thank you very much. Now, for the upcoming surgeons, to me, you showed me some complications that can actually cause lifelong outcomes to the patients. For upcoming surgeons who are going to work in this area, uh, what is your best advice for them to be good, to be excellent, to be great for their patients?
Practice, practice, practice. I think they need to have as much exposure and as much experience as they possibly can and find a good mentor that will teach them. I think the apprenticeship model is really the best way to learn surgery, where you have graded experience. And as you get better and better, you learn more and more until one day you look around and it's time for you to do the operation yourself. To become a pediatric surgeon, as you I'm sure know, takes, at least in the United States, 5 years learning adult surgery called general surgery, and then 2 additional years for pediatric surgery to learn how to do that kind of surgery, but in a child. And then I also did additional training in colorectal surgery. So that was about 8 years of work to be able to graduate. We talk about doing many operations and getting better and better at that until you can do it yourself.
Awesome. Lots of hard work goes in before you can actually start helping patients. Thank you so much for your time. Thank you for being with us.
It's always a pleasure. I look forward to the next session.
Yep. So we would set up the next session. We'll go from there. Thank you so much. This is very generous of you to share this information with me, with the cool beans. This is very valuable as well. So
It's
once
my
again,
pleasure.
thank you very much. See you next time.
Take care. Thank you.